I want to introduce our next speaker. So our next speaker will be Dr. Ihab Kamel. Dr. Kamel is actually a good friend, and I would say one of the best hepatoradiologists in the world. I consider whatever this individual says to be gold. Dr. Kamel is the vice chair of MRI operations at Johns Hopkins University, where he has a very busy clinical practice, but then also is a leader in translational work around novel imaging of primary and secondary tumors of the liver. So we're incredibly lucky to have Ihab with us today to talk about radiologic imaging of ICC. So Ihab, I'll turn things over to my friend.
Well, thank you very much for the introduction and your kind words. Can you see my slides?
Yes, we can.
Okay, great. Thank you again, Tim, for the introduction and your kind words. It's a pleasure and an honor to be here. And I also want to thank Dr. Ramandori for the invitation here and a great lecture series. And I'm super excited to be here and attend more of the lectures as well. So without further ado, I was asked to talk about radiologic imaging of intrahepatic cholangiocarcinoma. And as Dr. Pollack alluded to, it's something that's really dear to our heart, and we partner together and we continue to do so to have better imaging characteristics and better identification of these tumors, to assist in better management and better response to therapy assessment as well. So here's an outline of what I will be talking about. Briefly, a couple of slides about the introduction, about presentation, and Dr. Washington did a great job about risk factors, so I'm not going to get into that too much. We'll talk about the classification of cholangiocarcinomas, but then my main focus will be imaging findings, ultrasound, CT, and the role of volumetrics in CT, MRI, MRCP, and volumetrics as well. I will touch upon the role of hepatobiliary contrast agents, then talk about PET, cholangiocarcinoma. Definitely, oftentimes we get PET for staging and for assessing, for follow-up to assess for recurrence as well. Something that Dr. Kong alluded to, which is the mixed type or the hybrid HCC cholangio. And I'm going to share with you a couple of slides from the revised LIRADS about LIRADS M, which is the malignant category, oftentimes may include cholangio. Then I'll share with you our response assessment criteria, the limitation of current approach, including the conventional criteria, RECIST, MRECIST, and ESOL, and what we currently utilize to assess response using functional MRI. Briefly, as was mentioned by Dr. Washington, cholangiocarcinoma is the second most common primary hepatic tumor. The incidence is about 2 in 100,000, certainly more in Asia, and about 3,000 cases, new cases in the United States annually. Typically in the older 50 to 70 old age group, slightly more predominant in males than in females. And it arises from the intrahepatic bile ducts or extrahepatic bile duct epithelium. Going to the symptoms, unfortunately, the intrahepatic type is often incidental, but if there are evidence of obstruction, oftentimes there is all the imaging, the clinical symptoms of biliary obstruction, including jaundice, itching, clay-colored stools, weight loss, right upper quadrant pain, and weakness as well. Risk factors, again, were mentioned, so I'm not going to get into that, but highlighting cirrhosis. Cirrhosis, we're seeing more and recognizing more cholangiocarcinoma in the background, cirrhotic liver, than what we have anticipated maybe 5-10 years ago. Certainly congenital malformations, as was mentioned, chronic inflammation, infection, and perhaps the most established is the primary sclerosing cholangitis. And this is one example of a PSC where you can see the beaded appearance, the irregularity of the ducts, and you can see here on MRCP as well as ERCP the manifestations of PSC. Oftentimes, these patients are at risk of developing cholangiocarcinoma. Here's a clinical conundrum. When we are faced with the imaging or to rule out cholangiocarcinoma, oftentimes these happen in a background abnormal liver, such as PSC or cirrhosis. So it becomes a little bit more challenging to detect the mass. I will talk about LIRADS and its role because what we have thought to be HCC in the past oftentimes ends up being a mixed type or a cholangiocarcinoma. So I'll share an example with you. Also, it's difficult to distinguish a benign from a malignant stricture by imaging alone or by serum biomarkers or biochemically. So oftentimes we use CEA and CA19-9 with high sensitivity and specificity. And when these values or biomarkers are elevated, oftentimes the disease is more advanced. We talked about the classification and our focus on the intrahepatic type, which is usually the more common type. It is often peripheral within the hepatic parenchyma. It could be exophatic or polypoid, and sometimes infiltrative as well. When it's more central, it's more Klatskin type, and it could be purely ductal, periductal, or presenting as ductal, wall thickening, and the stricture, and that's beyond the scope of this presentation. So starting with ultrasound, oftentimes that's the primary imaging modality, right upper quadrant pain, or in a cirrhotic patient screening for mass. So oftentimes we see a poorly defined mass with or without ductal dilatation. So we look for the ductal dilatation, and oftentimes the epicenter or these ducts point us to where the possible mass is. Oftentimes the mass is poorly defined, slightly of mixed echogenicity. Oftentimes there is portal venous invasion as well. More commonly, we use ultrasound to guide biopsy if biopsy is indicated. This is an example of a right upper quadrant ultrasound, and you can see here the dilated ducts, mildly dilated, and then you go a little bit more centrally and you see a poorly defined mixed echogenicity mass in the left lobe of the liver. So this is a very large mass leading to ductal dilatation. Is this going to be diagnostic of cholangio? Usually not. There will be a second imaging, typically CT. So CT delineates the site and cause of biliary dilatation or obstruction. We typically do it as a dual phase, meaning arterial and venous phase, because we want to assess the vasculature. We may end up doing volumetrics if there's a potential resection. Infiltrative tumors are homogeneous with low attenuation, and the enhancement is typically peripheral. So this is something very important because of the predominant fibrous tissue. It starts peripheral and it persists for a long time. This is very different from HCC and oftentimes have a target or a targetoid appearance. And I'll show you some example. And capsular retraction is one of the things that we look for because it's very, when we see that, we know we're dealing with a cholangiocarcinoma. This is a very nice example where you can see the rim enhancement. If this is an HCC, it will be uniformly or mixed hypervascularity. When we see a rim, when we see capsular retraction, and you can see here the heterogeneity and the persistence of enhancement, this is not washing out. This is continuing to fill in. And in a heterogeneous pattern, this was a case of an intrahepatic cholangiocarcinoma. We look for vascular involvement. You can see here the amputated anterior right portal vein, something that we often look for to make sure that there's no vascular involvement. Here's another example where you can see the ducts pointing to a more hilar mass, and this is part of the mass. We look more superiorly. You can see a large infiltrative mass, again, poorly vascular with a little bit of a rim around it. This is very concerning for a cholangiocarcinoma. And you can see the amputated biliary tree here. Here's another example of a CT of intrahepatic cholangio. You can see a large mass with capsular retraction, with ductal dilatation, oftentimes with large adenopathy. We oftentimes may mistake this for an HCC because you end up seeing evidence of portal hypertension, but certainly this background liver is non-cirrhotic. The portal hypertension is because of the portal vein involvement here and resulted in splenomegaly and ascites. So sometimes distinguishing between an HCC and cholangiocarcinoma can be a challenge. Here's another example of an intrahepatic cholangio, poorly vascularized, and you can see the ducts radiating from this area, and you can see the distal ductal dilatation. Looking at the portal vein as well, you can see here that the narrowing and the caliber change of the right portal vein, and you can see the dilated ducts in the coronal plane. This was an intrahepatic cholangio. What about MRI and MRCP? Definitely is great for defining the tumor extent. So everything that CT would show will be also apparent on MRI with additional features. You will see the bile ducts better. It's non-invasive, so it's better than an ERCP, no ionizing radiation. And it delineates the vascular involvement similar to what you would get with CT. We can often do volumetrics if needed as well. Infiltrative cholangiocarcinoma is poorly defined with low signal on T1 and high signal on T2, a little bit of edema there. And oftentimes we may see the mass extending along the ducts, causing ductal dilatation. Here's one example where there's a very large infiltrative mass. You can see here on T1 unenhanced, it is poorly defined and it is low in signal, and you can get a hint of some dilated ducts more distally. In the arterial phase, there's a rim of enhancement, very heterogeneous enhancement. On the delayed 3-minute phase, you can continue to see the enhancement gradually filling in with areas of central necrosis. So the combination of rim enhancement, some capsular retraction, dilated ducts with continued fill-in would point us to the diagnosis of cholangiocarcinoma. Oftentimes it metastasizes. This was one extreme where you can see a lot of liver lesions here with innumerable hepatic metastasis. This was biopsy, and this was all cholangiocarcinoma metastatic within the hepatic parenchyma. Role of Avast or the hepatocellular contrast agents. These are contrast agents that we use to define and better assess tumor burden, because cholangiocarcinoma does not contain functioning hepatocytes. So on the delayed phase, the liver would be very bright, and that's typically around 20 minutes. And if there is a mass that is non-enhancing on the delayed phase, in addition to your T2, the capsular retraction, you can confirm that this is a non-hepatocellular tumor. And in the setting of cholangiocarcinoma, this is the primary mass. But if you notice here, there was a subtle lesion with no uptake at 20 minutes, moving more inferiorly, subtle T2, subtle enhancement, no uptake on EFS. So you start to see all these intrahepatic metastases that would be valuable to know of, especially if the patient is a surgical candidate. So hepatobiliary contrast is very useful in the setting of staging of cholangiocarcinoma. If there's any potential resection or for vascular mapping, we can use here as a CTA, venogram, and you can get the same information on MR. You can map the hepatic artery, you can map the portal vein, the hepatic veins. We can do segmental calculations and predict future liver remnant as needed in a potentially surgical cases. Now, PET-CT is very important because it has high sensitivity in nodular cholangiocarcinoma, not as high for the infiltrative type. So anytime we suspect cholangiocarcinoma, we may end up getting a PET or a PET CT for better staging. Now, there are some false positive, especially in the setting of PSC, primary sclerosing cholangitis, or if there's any inflammation or inflammatory changes, especially after biliary manipulation. Oftentimes, these patients come after the initial diagnosis with a stent in place. So the question is the uptake around the stent from the tumor, or is it related to the recent stent placement? Here's some examples of a positive PET, and you can see the large mass in the gallbladder fossa, also invading the gallbladder with a few other foci, better seen on PET here in the left lobe of the liver. Also, PET will pick up lymph nodes, and if we have any concern by imaging and they're PET positive, they're usually more suspicious. There's another mass, large mass in the dome of the liver, and you can see here the heterogeneity on CT and the very intense uptake on PET. This is another example where you can see the ducts dilated in the left lobe and segments for A and B, and some segment 8 as well. Very subtle lesion here on CT, subtle on T2 MR, and then you do volume rendering, and you see these ducts going or radiating from a mass that is best seen on MR arterial phase here with surrounding perfusion change, REM enhancement, very positive uptake on PET. This is all consistent with a cholangiocarcinoma. Just a few words about LIRADS, because this is very important. This is a cirrhotic liver, and you can see here a hypervascular lesion, not washing out, but has a target appearance. And that target appearance is not typical for hepatocellular carcinoma. When we got the MR and diffusion is a very water-sensitive sequence. Again, you see here the subtle T2 rim around the lesion. Anytime we see this, we need to, this is not a LIRADS 5, this is a LIRADS M, and more we're seeing the mixed type, as in this case, this was a hepatocellular carcinoma with a cholangiocarcinoma, different outcome, different management. That's why it's important to realize that if it's not a typical LIRADS M5, that we categorize as LIRADS M, and oftentimes we need a biopsy. And I'm constantly reminded by the revised LIRADS group that the risk of HCC is 33% in LRM, 66% could be other malignancy, typically either pure cholangio or a mixed cholangio and HCC. And again, here it shows that we are taking that more into consideration now because these tumors have different biologic behavior and different outcome. Briefly talking about treatment and assessing response, whether it's chemotherapy or whether it is chemoembolization or more recently immunotherapy, imaging is often required to assess response. And certainly can use biomarkers and lab values to see if CA19-9, for example, is going down after therapy. That usually indicates a favorable response. But oftentimes we rely on imaging. And this is one example where there was a lot of vascularity. And you can see the lipidal deposition post-angio here. And this was a treated lesion. Now, the question is, how do we assess response? As many of you know already, oftentimes these tumors are poorly defined, they're irregular in shape, and they don't shrink post-treatment. They may become less vascular. So we rely on RECIST, but RECIST may not show shrinkage. If you rely on mRECIST, in our experience, it's very difficult to determine where the residual enhancement is, especially in something that is REM enhancing or irregularly enhancing, the same challenges with ESOL. So our team, partnering with Dr. Pollack at Hopkins, we published one of the very first articles back in 2012, looking at how volumetric MR acquisition assessing changes within the entire tumor volume by apparent diffusion coefficient, which is routinely acquired in MRI, we were able to better stratify responders from non-responders by looking at apparent diffusion coefficient. Most of these tumors in 29 patients were in the stable group by RECIST, and that's no surprise. They remain stable in size. EASL was not assessed in about a third of them. Again, that's no surprise, but 21 of the 29 patients achieved partial response based on changes in motion of motor water molecules within the MRI studies. We followed this by a larger data set, 94 patients, looking at unresectable intrahepatic cholangiocarcinoma and looking at survival assessment and prediction using viable tumor burden, which is percent of tumor volume to the liver, as well as the ADC, the apparent diffusion coefficient. And we were able to better stratify responders from non-responders based on tumor burden and changes in ADC. Typically, if the tumor is very viable at baseline and small burden, these are more likely to respond to chemoembolization as opposed to a very large tumor burden and already necrotic tumor, unlikely to respond to chemoembolization because it's already necrotic with poor vascularity, and the large burden will negatively impact survival. So this is what we currently use today. We measure tumor volume, we measure the ADC, and try to predict response. So this was a quick overview looking at the role of imaging using ultrasound. Typically, it's a large mass with ductal dilatation. We often use it to guide biopsy. CT is used for staging, looking for vascular involvement, looking for volumetric assessment as well. MRI and MRCP, in addition to staging and vascular involvement, we can assess volumetrics. PET is essential, and we always get it to stage patients at presentation and look for any recurrence. Keep an eye on LIRADS and be very aware of the need to biopsy if this is not a LIRADS 5, it's a LIRADS M, because it could be a cholangiocarcinoma or a mixed type, not a hepatocellular carcinoma. We briefly talked about response assessment and the limitation of the current criteria, and we currently use volumetric criteria that include diffusion and tumor burden to better predict tumor response. And with that, thank you for your attention.
Thank you very much, Dr. Kamel, for really what is a tour de force of reviewing state-of-the-art imaging for intrahepatic cholangiocarcinoma. And I